Hello everyone and welcome to the new topic on in oral pathology oral medicine, which is fibro-osseous lesions. So in this topic the learning outcomes for the TTS curriculum are as follows. By the end of the topic you should be able to classify fibro-osseous lesions, and you should be able to explain the etiology, clinical and histopathological features of fibrous dysplasia, ossifying fibroma and cementosseous dysplasia. Okay, so let's first see what is fibro-osseous lesions. So fibro-osseous lesions are a diverse group of processes characterized by the replacement of normal bone by fibrous tissue containing a foci of mineralization that vary in amount and appearance. So this explanation is one of the most important aspects of understanding what is fibro-osseous lesions. So this is a very, first of all, this is a process, right? And is a group of lesions where what really happens is that the normal bone gets replaced by fibrous tissue, and then in that fibrous tissue there is foci of mineralization that develops, and slowly that foci of mineralization constantly may increase in amount. Okay, now based on this uh, uh, characteristic process, there are group of lesions. So the WHO, let's look at what these has classified fibro-osseous lesions of the maxillofacial region area over the course of many years. Okay, and one of the latest classification is the 2017 classification, wherein fibro-osseous lesions, that means lesions of the head and neck, wherein the bone is replaced by fibrous tissue and then the fibrous tissue undergoes mineralization, is categorized as follows. All right, so number one in that list is fibrous dysplasia. Okay, under fibrous dysplasia we have three types. We have monostotic fibrous dysplasia, polyostotic fibrous dysplasia and craniofacial dysplasia. Now monostotic is when one bone is affected. Polyostotic is, poly means many, ostotic means many bones are affected. That's when you call it polyostotic fibrous dysplasia. Craniofacial fibrous dysplasia is specifically when the bones of the craniofacial region are affected. Second category is cementosseous dysplasia. Okay, so cementosseous dysplasia, also abbreviated as COD. Okay, under that you have periapical, focal, florid, and familial gigantiform cementoma. The third is ossifying fibroma, which is further classified as conventional ossifying fibroma and juvenile ossifying fibroma. So now I'm going to explain further about this classification and these lesions as we go forward. Right, now when we look at fibro-osseous lesions, right, as we've understood, normal bone is replaced by fibrous tissue. That fibrous tissue undergoes mineralization. That's what is fibro-osseous lesions. It's a process. All right, now these fibro-osseous lesions collectively are categorized into three types. All right, developmental lesions, which is what is fibrous dysplasia. Reactive lesions, that means they occur secondary to inflammatory components, which is cementosseous dysplasia, and the third component, which is neoplastic. Neoplasm means new growth, and under which comes the benign neoplasm ossifying fibroma. So at the previous slide, the 2017 classification, basically if we look at it, fibrous dysplasia, under which we have monostotic, polyostotic and craniofacial. Cementosseous dysplasia, under which we have periapical, focal, florid and gigantiform cementosseous dysplasia, and under ossifying fibroma you have conventional ossifying fibroma and juvenile ossifying fibroma. So when you look at their origins, they are categorized as developmental lesions, reactive lesions and neoplasm. All right, now what is the difference between the three? Developmental lesions basically arise during the early life of a child. They increase in size as the child attains puberty, and once the growth potential is stopped, the lesion is believed to stop growing. So basically these lesions, developmental lesions, are generally self-limiting, right? Reactive lesions are lesions that occur secondary to inflammation. So that means cementosseous dysplasias typically arise in tooth-bearing areas in the periodontal region, and inflammation of the periodontal apparatus is one of the causes of this lesion. Neoplasm, on the other hand, is new growth, right? So, new growth, the difference between developmental lesions and neoplasm is that neoplasms do not stop growing, right? So, basically, once there is that mutation that has taken place and a lesion starts to proliferate and grow, this benign lesion has a constant, persistent growth potential as against developmental lesions, which will stop growing once the growth phase of the child is over. Okay, I hope I've made this clear. Let's look further now. So, number one, let's look at fibrous dysplasia. Now, fibrous dysplasia is a developmental tumor-like condition characterized by replacement of normal bone by an excessive proliferation of cellular fibrous connective tissue intermixed with irregular bony trabeculum. So, that is the same process as fibro-osseous lesion, right? Now, this occurs because of a mutation, all right, and the mutation that takes place is basically this GNAS gene, right? So, which leads to a defective protein. So, guanine nucleotide binding protein, alpha stimulating activity polypeptide 1 gene, right? So, this protein, when it is defective, it leads to fibrous dysplasia. Now, fibrous dysplasia can be majorly of two types, all right, monostotic and polyostotic. So, as I already told you, when one bone is affected in the entire body, it's called monostotic. When many bones are affected, it's called polyostotic, right? And craniofacial is when maxillofacial region is affected. So, let's look at these two major types. So, monostotic fibrous dysplasia of the jaw, the clinical features are it's limited to a single bone. 80 to 85% of all cases are monostotic fibrous dysplasia. Now, jaws are most commonly affected. Second decade of life, most common age of occurrence. It is equal sex predilection. That means there is no particular gender that is commonly affected. Painless, it arises as a painless slow growing swelling of the maxilla, all right, commonly affecting the maxilla. Okay, so radiographic features in the early stages, all right, there is mixed radio opaque radiolucent lesion, or the appearance is also described classically as ground glass appearance. Now, the lesion is not well demarcated, all right, and it has very most times it has diffuse margins. Periapical radiographs show narrowing of the peripedial space with ill-defined lamina dura. So these are classical features of fibrous dysplasia. So here we have a case here. This is and there is an expansile mass of the left maxilla here that we are seeing, right? When there's a swelling like this, definitely there is discomfort in eating, chewing, swallowing, as well as speech, and then the patient turns up to a dental school or to a dental practitioner. When you After clinical examination, when you do the radiographic examination, you notice that there is diffuse ground glass appearance, right? Again, on OPG also, you're able to see a diffuse ground glass appearance that is very clearly evident, and our provisional diagnosis would be fibrous dysplasia. Now, polyostotic fibrous dysplasia is when multiple bones are affected, right? So, fibrous dysplasia affecting many bones is called polyostotic fibrous dysplasia. Now, under polyostotic fibrous dysplasia, we have two syndromes that have been identified. Number one is Jaffe-Lichtenstein syndrome, and number two is McCune-Albright syndrome. So, let's look at what these syndromes are. So, first of all, polyostotic fibrous dysplasia is not very common, right? As you're aware, it affects multiple bones. Yes, of course. Now, when you see fibrous dysplasia affecting multiple bones, plus there is cafe au lait pigmentation, or the pigmentation which is described as coffee with milk. Previously, in various other topics, I have explained what is cafe au lait pigmentation, right? So, cafe au lait pigmentation is basically coffee with milk pigmentation. When you see this skin lesions in association with polyostotic fibrous dysplasia, then it is described as Jaffe-Lichtenstein syndrome. When you see features of Jaffe-Lakinston syndrome, plus there are multiple endocrinopathies, then it is described as McCune-Albright syndrome. Okay, so this is how polyostotic fibrous dysplasia, Jaffe-Lakinston syndrome, and McCune-Albright syndrome are identified. Okay, so now let's look a little more detail about what is cafe au lait pigmentation. So cafe au lait pigmentation basically is coffee with milk pigmentation. So they are well defined unilateral tan macules, all right, commonly seen on the trunk and on thighs. They have irregular margins, all right. Okay, they have irregular margins. If these cafe au lait pigmentations have smooth margins, then we should be worried about neurofibromatosis. Okay, they are present since birth, so they are congenital, and pigmented oral mucosal macules may be present in these patients. Picture of a patient, okay, who has maxillary unilateral maxillary expansion, okay, enlargement of the right maxilla and the mandible, right, which is evident here on this picture, and this patient has cafe au lait pigmentation, right. So this is basically, so this patient is a white skin patient, right, where the complexion is fair, and then you are actually able to appreciate these tan macules on the skin. So when you see irregular margins, then we are looking at Jaffe-Lakinston syndrome. If this cafe au lait pigmentation has smoother margins, then this is not Jaffe-Lakinston syndrome, but we're looking at something else. More commonly, it could be neurofibromatosis. Now, McCune-Albright syndrome, all right, so is all features of Jaffe-Lakinston syndrome plus multiple endocrinopathies. Now, when we talk about multiple endocrinopathies, it could be sexual precocity. So, sexual precocity basically means when a female, okay, attains early puberty, right? So menstrual bleeding that is seen in the few months of life, breast development and pubic hair in the first few years of life, right? So this is because of an endocrinopathy, all right? There are other endocrinopathies that have also been identified in patients with McCune-Albright syndrome, such as pituitary adenomas or hyperthyroidism. Okay, now this pattern is classified is described as McCune-Albright syndrome. Okay, so here we can see a CT image here, right, of showing the skull and the maxilla. So here we are seeing extensive involvement of the maxilla and skull. So when the maxilla is involved, the lesional tissue generally displaces the sinus floor superiorly and commonly obliterates the maxillary sinus, which is clearly evident in this case. Okay, and when the skull and the maxilla is involved so extensively, it is more towards craniofacial fibrous dysplasia. Right. The second photograph here is actually a continuum of the case that I showed you, where you've seen the maxilla and mandible uh, swelling, as well as the radiograph here and the cafe au lait pigmentation. So this is that patient and who's diagnosed with Jaffe-Lakinston syndrome. So under polyostotic fibrous dysplasia, we have Jaffe-Lakinston syndrome and McCune-Albright syndrome. Okay, so let's come to the histopathology. Either way, whichever type of fibrous dysplasia will have the same histopathology based on where the specimen is taken from. So because this is normal bone replaced by fibrous tissue which gets mineralized, what we generally see in histopathology is irregular shaped trabeculae of immature bone in cellular loosely arranged fibrous stroma. The bony trabeculae are not connected to each other. You see curvilinear shape, which is described as Chinese character or Chinese script writing. Okay, it's not surrounded by plump osteoblasts, so osteoblastic rimming is not seen. Tiny calcified spherules are rarely seen, and generally this microscopic image of fibrous dysplasia is described as monotonous pattern. So this is the microscopic image. So basically this is the fibrous tissue, this is the mineralized component that we are seeing. Okay, So normal bone. So obviously, if we've taken this specimen from the swelling in the maxilla, so if this was normal bone, then we would have seen cancellous bone. But here, cancellous bone has been replaced with mature fibrous tissue, which is further undergoing mineralization. And this is basically the curvilinear pattern of mineralized ossifications that are. And this is the hyper image of the slide. Basically, you're able to see the ossification, but there is no osteoblastic rimming that is visible. Okay, so in fibrous dysplasia, 0.4 to 1% chance of malignant transformation is seen. Monostotic is when single bone is affected. Usually, it affects the maxillofacial region. When a patient has polyostotic, generally the bone that is affected is femoral and maxillofacial. And in terms of malignant transformation that can take place in fibrous dysplasia, the highest chance of malignant transformation is osteosarcoma, followed by fibrosarcoma, and lastly, chondrosarcoma. Okay, so I would like to mention here that when we spoke of fibrous dysplasia, we're talking about it under the category of developmental type of fibrous lesion. So, as you're aware, developmental lesions are will stop with once the child finishes the growth spurt. So these lesions generally regress and can be managed once the growth phase is over. But many a times, if the lesion continues to grow, causes asymmetry and leads to facial deformity, then it is treated um, with surgical recontouring. Okay. All right, so let's move to cementosseous dysplasia. So cementosseous dysplasia, previously in the 2005 classification of the WHO, was called osseous dysplasia. Now, these lesions, these fibro-osseous lesions, is among the most common ones that we see in dental practice, right? They occur in tooth-bearing areas of the jaw. They're the most common fibro-osseous lesions. The possible etiology that it has been attributed to is periodontal ligament origin, basically a defect in the extra ligamentary bone remodeling, and some hormonal imbalance, which leads to these lesions. Now, these lesions are clinically and radiographically categorized as four types: periapical, focal, florid, and gigantiform cementoma. So, let's look at each one of them as we go. So number one is periapical cementosseous dysplasia. So as the word goes, it's periapical. So it's commonly seen in the periapical region. Most common area that it affects generally is the mandibular anterior teeth, right? So there is a female to male predilection of 10:1. That means more commonly in females. The ethnicity that is commonly affected, the race that's commonly affected is blacks. Between the age group of 30 to 50-year-olds, all the mandibular anterior teeth will be vital. Okay, so in this case, we're talking about a fibro-osseous lesion. So again, I'm going to bring your thoughts back to the process, right? The explanation of the process. Fibro-osseous means normal bone replaced with fibrous tissue. Fibrous tissue undergoes mineralization. Here in this case, this is happening in the anterior mandible, right? That means affecting teeth, mandibular anterior teeth. All those teeth, when you check the vitality, will be vital, but the periapical bone will show this fibro-osseous change. So when this fibro-osseous change is taking place, the bone will show radiographic changes, which I will explain moving forward. So these patients are generally asymptomatic. So there's no complaint as such. And these lesions seldom exceed more than 1 centimeter in size. Okay. So radiographically, there are three stages, right? The early stage, obviously, since this is normal bone that is being replaced by fibrous tissue, you're going to see circumscribed area of radiolucency, apical area of the tooth, right? So if we are looking at, let's say, 3-1 and 4-1, this patient has come for a routine checkup, and suddenly you see a radiolucent lesion attached to the periapex of 3-1-4-1. Of course, you're going to think of some periapical pathology, but before you jump to conclusions, you need to check vitality. If the tooth is vital, then there is a very high chance that this is an early lesion of a fibro-osseous lesion of the type periapical cementosseous dysplasia, right? With time, this radiolucency goes on to envelop the apices of the teeth, and with as it matures, this radiolucent lesion will develop radio-opaque specs and radio-opacities, right? As the lesion matures, there will be more dense calcifications that surround, but there will be a radiolucent rim. So this is what I mean. So multiple radiolucent lesions that are seen at the apex. You see one, you see two, three, four, right? Now, during late stage, these same areas basically they show opacities, later exhibiting significant mineralization, right? So there is radio opacity around that there is a rim of radiolucency, right? So these clearly show various different stages of periapical cementosseous dysplasia. Of course, here in this image, you're also seeing a crown that has been put, a fixed partial denture that's been put, right? There's a missing tooth here, and so um, periapical cementosseous dysplasia come under the category of reactive. So there has to be some reactive process which leads to this periapical change. Now it's very easy to be misled that because of these processes that is present, this lesion could be a cyst or a granuloma, but you've got to take care and you've got to assess what uh, is whether the tooth is vital here, because here RCT has not been done, right? So if these teeth are still vital, then definitely we are not looking at a periapical pathology, but we are looking at a fibro-osseous lesion, more commonly a PCOD. Okay, so if you really do a biopsy of this lesion, what are you going to see? You're going to see fragments of cellular mesenchymal tissue, fibroblasts, collagen fibers with numerous blood vessels, and a mixture of woven bone, lamellar bone, and cementum-like particles. Right? How do we identify cementum-like particles? As we've discussed during the various slide discussions, cementum is always basophilic on H&E, right? So if we see basophilic calcifications, more or less they are cementum-like particles. A final radiopaque stage, if a biopsy is taken when it's final radiopaque stage, then you're going to see more trabeculae fuse and which form globular masses composed of sheets of acellular disorganized cementosseous material, right? Right, so this is what we mean here. So fragments of cellular connective tissue containing trabeculae of bone, okay, spicules of cementum, like particles with moderate stroma. So all this pink area is basically your fibrous tissue. These basophilic areas are cementum-like areas, all right? So at late stages, you see basically sheets of these sclerotic masses of cementum and osseous material. Okay, so what is the difference between periapical COD and focal cementosseous dysplasia? Well, when only one site is involved, that means one tooth is involved, then we call it focal cementosseous dysplasia. Periapical cementosseous dysplasia affects all the anterior mandibular teeth. Okay. Again, there's a female predilection, affecting the third to the sixth decade. Any area of the jaw can be affected, but the most common area is posterior mandibular teeth. Lesions are asymptomatic and smaller than 1.5 centimeter. Many times it is believed that these focal cementosseous dysplasia are a transition to multifocal involvement. So basically, at what time a patient comes to the dentist, at what time you have, at what stage of the maturation of the lesion you have taken the radiograph, you will be coming up with a diagnosis. So this is a radiograph, right? Clearly showing mandibular posterior teeth, right? Which shows a radiolucency over the course of time. The same patient, after many years, after 9 years, shows radiopacity. So at this point, when this patient has come, if this tooth is vital and this radiolucency is present around, then most probably this is a focal cementosseous lesion. Right, so let's look at the next one, which is florid cementosseous dysplasia. So when we use the word florid, it means multifocal involvement. What is meant by multifocal? Multifocal means more than one. So usually they are bilaterally present and symmetrical involvement is seen. And again, the lesions are very similar to the previously described periapical and periapical cementosseous dysplasia. Female predilection is seen, right? Now, the difference between florid cementosseous dysplasia and gigantiform cementoma is that in gigantiform cementoma, there is all four quadrant involvement, right? So it is more aggressive, and it is previously was used as a synonym for florid, but now it's not. Okay, it's also been identified that familial gigantiform cementoma is an autosomal dominant disorder that demonstrates very high penetrance. That means if either of the parent has it, the immediate offspring has a very high chance of having the same lesion. Okay, again, more or less, most other features are very similar to the previous described lesions. Now this is the florid cementosseous dysplasia example. So you're seeing yellowish avascular cementum-like material, which is beginning to exfoliate from the mucosa. When a radiograph was done, what was noticed is multifocal radiopaque lesions of the posterior areas of the jaws are seen. Look at this area, look at this area, look at this area, right? So this is florid cementosseous dysplasia. Now, these lesions, management of these lesions, generally if patients are symptomatic, the management is quite difficult. Okay, it depends on the stage and depends on the symptoms and the difficulty that the patient is having. Many times, this bone, the sclerotic components basically are surgically recontoured to basically try and treat the complaint of the patient here. Okay, so now let's look at ossifying fibroma. Now, ossifying fibroma is a neoplastic type of fibro-osseous lesion. That means that it has a certain amount of growth potential and continues to grow unless and until it is treated, right? That is the difference between developmental lesion and a neoplastic lesion. Now, under ossifying fibroma, we have two types, conventional and juvenile. So let's first look at conventional ossifying fibroma. So it's a true neoplasm with a significant growth potential, as I've already told you. It resembles focal cemento-osseous dysplasia radiographically and to a lesser extent histopathologically. All right. Now, the etiology has been believed to be odontogenic or periodontal ligament in origin. The neoplasm is composed of a mixture of bony trabeculae, cementum-like spirules, or clinical features. It commonly affects third to fourth decade of life. Female predilection again seen. Mandibular, premolar, and molar region most common area. It rarely erodes or displaces teeth and are slow growing and expansile. So these patients basically come with a swelling of the jaw or the mandible, and when you actually examine them and you do the radiograph, you will be able to identify these lesions in these areas. Larger lesions are generally painless swellings of the involved bone. Chief complaint of the patient usually is asymmetry. Radiographically, what we see will be a well-defined and unilocular mixed radiopaque lesion, right? Commonly, root divergence or resorption of roots of the associated teeth is rare. So let's look at this here. There's a maxillary enlargement of the posterior maxilla, mixed radiopaque radiolucent lesion that is seen. Okay, now this is actually a rare case. More commonly, ossifying fibromas affect the mandible. So histopathologically, so again, it's a fibro-osseous lesion, so fibrous tissue, varying degree of cellularity is seen, contains mineralized material. Now the hard tissue portion may be in the form of osteoid, so that means bone-like, and bone, or basophilic and poorly cellular spherules-like structures or cementoid-like material. Now, peripheral osteoid and osteoblastic rimming is present. So that is the histological difference between fibrous dysplasia and the major difference between fibrous dysplasia and ossifying fibroma. So this is the microscopic image. So mixture of woven bone and cementum like this basophilic is cementum. All of this is fibrous tissue. This is the bony trabeculae that you're seeing, or the osteoid. Okay, same thing. So well circumscribed solid mass of tumor. That's why you're seeing a clean cut here. All right, trabeculae of bone and droplets of cementum like material in the background of fibrous connective tissue. So whenever we're talking about fibro-osseous lesion, it's basically normal bone replaced by fibrous tissue. So microscopically, if you can identify fibroblast, collagen, osteoid, you should be able to identify these under the microscope at the undergraduate level. So coming to treatment now, since ossifying fibroma, conventional ossifying fibromas are well circumscribed lesions, that means generally they will have a well-defined mixed radiopaque lesion with a peripheral rim, right? They are easily enucleated, so they can easily be enucleated, and the prognosis is good. So there is the recurrences are rare, malignant transformation is not seen. So that's good news about ossifying fibromas. On the other hand, when we look at juvenile ossifying fibromas, now juvenile ossifying fibromas, these lesions are different from conventional ossifying fibromas because of the age of occurrence, okay, the site that commonly affect, and the clinical behavior. So let's look at it. These, first of all, age of occurrence, mean age of diagnosis ranges from 11 to 22. They have a male predilection as against conventional ossifying fibroma, which is female predilection. The site is maxillary predominance, all right, more commonly seen in the maxilla. And the two histological types are trabecular and seminoma type. Okay, clinical behavior wise, these lesions are more aggressive than conventional ossifying fibroma. So if the lesions are small, they are treated with excision. If the lesions are large, then they are treated with curettage. Now the prognosis of juvenile ossifying fibromas is fair to poor, because the recurrence rates are very high. That is 30 to 50% recurrence rate that is seen. Okay, so this is a general outline of fibro-osseous lesions. There are a lot more content that is available for you to understand the core concept I have explained here. More discussions we will have when we actually discuss the CBLs in the lab. All right, thank you.